So I have the pleasure to announce you the first session. So we start with the UK and a very topical subject, the relationship between the NHS and the private healthcare and the analysis of what's happening with COVID. The paper is provided by Mary Gay from Lancaster University, and we will have Sarah Reed from Nuffield Trust who will discuss the paper afterwards. So with this, I'll give the floor to Mary. I think you have your slides on already.
Okay, can everyone see those?
Yes, we can.
Okay, great, that's fine. Okay, thank you. I'd like to start by thanking Rocco, Lucy, Zainab, and Sarah for discussing this afterwards, and generally LSE Health Policy for giving me the opportunity to talk to you this morning. It's a great pleasure to be in such a diverse and interesting meeting today. So the question I'm asking is COVID-19 reframing the relationship between the NHS and private healthcare in the UK, and if so, how? It comes with a caveat. I've mentioned the UK. It's a work in progress, so the focus at the moment is largely on England. I make some reference to guidance and regulations in Scotland and Wales as well. But this is an aspect of the paper I'm hoping to develop, so I'm certainly happy to have feedback regarding other countries of the UK. Obviously, the NHS is arranged differently across the 4 countries. Nevertheless, the private healthcare market is UK-wide in its scope, and the Competition Act 1998, which I'll be referring to briefly, is also UK-wide in its scope. So, in overview, what I'm going to talk about for the next 15 minutes is setting the scene, setting out the relationship between the NHS and private healthcare. So, in this sense, it builds on some previous research of mine. Firstly, a book published last year which looked at the Health and Social Care Act 2012 competition provisions, and an article in Legal Studies talking about the wider relationship between NHS and private healthcare and how these link with the competition provisions. So from this work comes this conception of the 4 categories, which I'll get into in a minute. And I'm going to be using that to talk about the pre-COVID situation and sort of where we are now. And then I'll be wrapping up with some initial concluding remarks. So just a quick note on terminology to begin with. The idea of NHS privatisation is probably familiar to many of you here, but just to be clear for others who've seen it but not quite sure what it's getting at, NHS privatisation typically refers to the expansion of private sector delivery of NHS services. It's been a matter of policies since initially the NHS internal market, but really taking off with New Labour via the coalition government and onwards. To a lesser extent, it can also refer to the expansion of NHS providers treating private patients, so in private patient units. But for the most part in the media, when it comes up in political discussions, it's referring to the private sector delivery of NHS services. This can be distinguished from the idea of where a patient moves from the NHS to the private healthcare sector. So one can inform the other. The framings I'm using in the paper in relation to COVID-19 are crisis and continuity responses, but obviously map onto other terminology as well. NHS England has its phase 1 and phase 2. So crisis, and what we see with both is interaction between the NHS and private healthcare. So in connection with crisis or phase 1, logistical support for testing, obviously a very topical subject at the moment, continues to be, and there's been a report by the British Medical Association on concerns about outsourcing. Continuity responses, phase 2, typically refers to the delivery of non-COVID-19 related healthcare services. How do we continue to provide that alongside responding to the pandemic? And this has formed the basis for an inquiry by the Health and Social Care Committee in the UK Parliament, where there's been a call for continued private sector, independent sector support of the NHS. In terms of defining continuity responses, we do, of course, and are increasingly confronted with aspects of the pandemic as they emerge. So the idea of long COVID, long-term conditions, ongoing health problems for those who've previously been diagnosed with the virus would seem to sit more effectively within this discussion of continuity responses rather than crisis response. But nevertheless is something which needs to be considered. So, by way of background to where we were this time last year, I've spoken briefly about the wider NHS private healthcare interaction. This was a long-standing relationship in existence since the inception of the NHS. It's also formed the basis for successive competition reforms from the NHS internal market onwards and the purchase of provider separation. And the combination of this, NHS and private healthcare purchase and providing separations, can give rise to these four categories. So category 1 could refer to NHS trusts, foundation trusts, and category 2 to private sector providers delivering NHS services. So categories 1 and 2 clearly relates to the NHS. Category 3, in a sense, is kind of a mirror image. It's about NHS providers treating private patients. So private wards and NHS hospitals. And category 4, private hospitals treating private patients. So 3 and 4, the private healthcare sector. This framing device of 4 categories has been developed in the context of discussing applicability of competition law, but can be used to discuss this wider relationship as well. So in the sense of going private, we're talking about a movement between categories 1 and 2 to categories 3 and 4. And this is underpinned by Department of Health guidance and NHS England guidance. Key factors to come out of this is a prohibition on co-funding. So in essence, avoiding the implication that the NHS is subsidising private healthcare. In the guidance is also reference to limited scope for co-payment. So this is where NHS patients pay or make some out-of-pocket expenses. Typical examples would be prescription charges. NHS privatisation is typically centred on category 2 in the 4 categories, possibly also category 3. And what's underpinning this has been successive policy, including the NHS Constitution, patient choice policies, which were in varying degrees enshrined with the Health and Social Care Act and associated secondary legislation. What we had last year was the introduction of the NHS long-term plan. I should explain, of course, the controversy that surrounded the Health and Social Care Act, competition and the NHS privatisation of the NHS remain very sensitive subjects. And the long-term plan, one of the aspects was to address some of this. So certain aspects were described in The Independent as by Sean Linton as removing competition law from the NHS. But it's actually quite limited in its scope as to what the long-term plan proposes to do. It doesn't address the wider inconsistencies about NHS and private healthcare interaction in the way that that may suggest. What I haven't put on the screen, but which is important here, is a bill that's being introduced by the Conservative MP Christopher Chope. It's called the NHS Co-Funding and Co-Payment Bill. It's been around for a couple of years. It's not got beyond a second reading, but a second reading is now scheduled for next week. And this seeks to remove this prohibition on co-funding and extend co-payments. So potentially quite significant if this gains traction. So that was to give an overview of this idea of 4 categories, the idea of movement between the NHS and private healthcare and how that can work. The guidance I've mentioned, Department of Health guidance, I'm aware of largely similar guidance existing in Scotland as well. Again, very happy to have feedback on the other countries of the UK. In terms of where we are now with COVID-19 and the changes that are coming in, the most notable thing perhaps is the deal, it's described as a deal collective agreement between NHS England and the Independent Healthcare Provider Network in March, and the purpose of this was to reallocate practically all independent sector hospital capacity to the NHS with reimbursement of cost. The effect of this would seem to be to shrink categories 3, more specifically category 4. Nevertheless, it hasn't had the effect of removing sort of the private healthcare market in its own right. There's been a second collective agreement, which has received less attention, which operates to reserve surplus capacity within private sector providers to treat certain categories of private patients. So there is clearly a desire to continue with the private healthcare market in that sense. In terms of this framing of crisis and continuity responses, obviously the first collective agreement, the big deal, was intended to run between March and June. So it seemed to suggest a sort of crisis response. What we've seen with the Health and Social Care Committee inquiry is that there's a need to continue this relationship. Independent sector healthcare providers have made important contributions. The examples given related to treating cancer patients and delivering home care services. Where we are now in terms of government commitments to this is perhaps a little less clear. So the idea being that these collective agreements can serve both crisis and continuity responses. The agreements are underpinned to a certain extent by 2 public policy exclusion orders, one addressed to patients in England and one in Wales. And the purpose of these orders is to relax application of Competition Act 1998. This is because an agreement typically between independent providers and the NHS may fall foul of the anti-competitive agreements provisions. These public policy exclusion orders have been introduced for other sectors as well, for example, in connection with groceries and dairy products. So in that context, it's to deal with potential shortages of supply. And in that context, obviously seen very much more in crisis response terms. In fact, the dairy product order expired back in August. The healthcare orders would seem to be quite different. On the face of it, again, part of this wider crisis response framework. So 2 aspects to flag up from the orders. Firstly, that they govern specific agreements, but the wording is actually quite wide-ranging. The purpose of the agreements protected is to assist the NHS in addressing the effects or likely effects of coronavirus on the provision of health services to patients. So effects or likely effects can be obviously interpreted potentially very widely indeed. And the duration of these orders are simply specified as the healthcare disruption period. So again, potentially quite a seemingly open-ended period of time. So there's two orders, one for patients in England, one for patients in Wales. Main differences between the two being the organisation of the agreements, reference to boards, for instance, and specifically to NHS England, and to the range of private independent sector providers involved in the agreements. Again, as I mentioned at the beginning, the Competition Act 1998 actually is UK-wide in its scope. So how this is being managed in Scotland and Northern Ireland is also of interest here. So I'm going to wrap up with some initial concluding remarks now. I've argued previously when I was discussing application of competition law that we don't actually have a single unified healthcare sector. What we have here is complex interaction between the NHS and private healthcare. So this was intended to counteract the argument that health is just like energy, it's just like the rail services, it's just like utilities. With the changes we're seeing, we seem to be perhaps moving more in that direction, that maybe it could in theory become possible to speak more about a unified healthcare sector in the UK. Nevertheless, as I've mentioned, there are clearly aspects which suggest that private healthcare is intended to continue in one form or another. We see this, for example, by comments by the Competition and Markets Authority in a merger earlier this year. They were taking the view that COVID-19 responses were unlikely to affect the long-term competitive dynamics of the private healthcare industry. Nevertheless, the relationship seems to be undergoing a sort of reconfiguration that would appear to need to continue. The 2020 orders, we are seeing the inconsistencies and unresolved tensions starting to come through in connection with Category 2. So, in essence, the 2020 orders are addressed to predominantly Category 2 activity and the potential expansion of this over time. Also reflecting the distinctions between countries of the UK, whilst working within these wider frameworks. Legislation which is UK-wide and the private healthcare market also being considered UK-wide as well. One thing this might indicate is the possibility to change some of the rhetoric on NHS privatisation. There's been some surveys to indicate that those who are typically opposed to private sector delivery of NHS services may be more in favour in the sort of as a short-term solution, but not in the longer term. So, how much that change will depend on how long these arrangements go on, presumably. So I'm going to leave it there for the moment. I'm very happy to take questions, and I'm looking forward to the discussion with Sarah now.
Thank you so much, Mary, for this very interesting presentation. So I think we will jump into Sarah's discussion, and you hold on to your questions, and you'll take more questions after Sarah's discussion.
Great, thank you. I'm just going to share my screen as well because I have some slides to help guide the discussion. But yeah, first, thank you, Mary, to that brilliant presentation, and Rocco for the invitation to discuss this very timely and interesting topic. Here we go. So yeah, just to reflect on Mary's paper to start. So I think this research provides a really helpful framework, I think, for understanding and categorizing some of the different forms of privatization we see in the NHS, concepts that I think often get a bit convoluted and murky in public discourse and debate. And I think it makes a really important contribution to this conversation by talking through some of those legal implications that Mary described of how this changing relationship between NHS and private healthcare might evolve. And it leaves us some with really important questions, I think, about what the implications might be for extending some of these contracts with the independent sector further, and how that may influence things like competition And I do think there was a really helpful distinction made in Mary's work between the different modes that the private sector works with the NHS, both in terms of that continuity and crisis function. And it points to some areas of overlap that may be more difficult to disentangle as we move through the next phases of the pandemic, and the relationship between the NHS and private health services continues to evolve. I think some areas where this research could be augmented even further come down really to context and kind of the backstory underpinning some of these legal implications. So one thing I was left wondering after reading Mary's wonderful paper was just, what is some of the nature of this anti-competitive paper? What does that really look like in each of the different forms of privatization that Mary described, and how might that evolve as a result of COVID-19? Mary also pointed to differences that are starting to surface between the different countries of the UK, and I think that would be really useful to expand on further as more details emerge, particularly in the different agreements that are being reached in Wales and Scotland and how those differ in England. I would also say, and though it may be outside of scope, but there's a lot of interesting learning to be drawn on from the broader European community. One thing I'll discuss later is how the NHS compares to what's happened in other health systems in terms of that changing relationship with the private sector. And the NHS isn't alone in continuing to draw on those resources in different ways as a result of their COVID response. And I think Mary's earlier work on the kind of the context and history of the NHS's relationship with the independent sector and private sector more broadly would be really important context to this question of how things are now, and making sense of how things are changing as a result of COVID. So maybe bringing those into this conversation, and something I hope to do in my portion of the conversation. And just thinking through further implications of COVID-19, I think Mary raised some really interesting questions on the legal side of things, but just understanding what this will mean directly for providers and patients, and which services are most likely to be affected by these evolving relationships would be really interesting to expand on and understand further. So in terms of what I'll discuss, I'm going to do my best at kind of providing some of that background and context of what privatization has looked like in the NHS and how this has evolved over time for those who may be less familiar. I'll expand on what Mary has already described and what seems to be changing under COVID-19, and where there's still unknowns, and something that'd be really interesting to explore and research further. And then, as I said, I will also think about how our experience here in the UK compares to what we've been seeing internationally. So just to start then with context, so, and this may be different in some of the countries that you're from, but certainly the idea of privatization is something that has been rife with controversy here in the UK. So, and often how privatization is discussed, it's described in different ways, and some of these concepts get a bit convoluted in public discourse, but really private companies have had a role in the NHS since its inception, but many see that the increasing role of private companies is a growing sign of evidence of privatization, and something that kind of cuts against the core values of the NHS. So it's something that has been controversial over time. But when you ask the British public, I think the British public tend to prefer a publicly run health service. That's what the best survey data we have suggests. This is unfortunately outdated. We haven't asked this question in more recent years, but in 2013, it was 84% of the public thought that the NHS should be run publicly. But while privatization is something that is certainly quite divisive politically, the headlines perhaps can be misleading or overstate how the public's own perceptions of privatization. So we have other survey data from the British Social Attitude Survey, and apologies again, this data is old, but it's the latest we had, found that actually only 43% of those polled minded whether or not their NHS-funded care was delivered by the NHS or other private providers. So while this is something that comes up a lot in the media, and something that certainly surfaced a lot in political debate, it's interesting to see how there might be differing views in the general public. But with that said, far fewer respondents to the survey said that they would prefer to be treated by a provider than an NHS one. So I think, as I mentioned, this data is old. It'd be really interesting to see how public views of privatization have evolved, particularly in response to COVID, as we do see this expanding relationship unfold. Now I'm going to attempt to answer how much of the NHS is actually privatized. And I'm going to draw on Mary's framework of thinking of those different categories of privatization. So starting with how much is the NHS buying from the private sector? So this is care that is publicly financed but privately delivered. So this, we've seen over time when we've looked at this at Nuffield Trust, that actually the percentage of health spending that goes to organizations that are non-NHS trusts or other statutory bodies has been a significant but fairly stable amount, hovering around 20% for the last 9 years that we've looked at the data. Some caveats here is that this is actually quite a hard figure to understand. There's lots of interpretation involved. So lots of judgment has to be placed in what we make of the numerator and what's counted as a non-NHS provider, as well as how we understand total NHS spend. But when we looked at this, we looked at all providers that are non-NHS and looked at that over time as a percentage of total spend to account for an overall increasing budget on health, and found that it is fairly stable and consistent throughout the past decade or so. What's included in that 22%? So that will include the independent sector, so private companies that deliver health services, but it also includes other things like services that are provided by the voluntary sector or social enterprises. It includes some of the relationships that Mary described, where an NHS patient might choose to have their care delivered by a private hospital, a choice that's been available to them since the 2000s. It also includes instances where the NHS will arrange for a patient to have their care delivered by a private hospital to help manage things like waiting lists and improve access to care. So that's all included in that figure. A more common figure we often see given by the Department of Health is around 7% of NHS purchased care is in the private sector. But that figure, I think, can understate the number because it doesn't include things like the voluntary sector, of which there are some companies there that are profit making. And it also, it doesn't include, for example, services that are commissioned by local authorities, which are often then contracted to the independent sector. So it might not give us a full picture of what is actually being privately provided. I should also say in that 22%, that also includes a lot of services that I think the general public would consider NHS. So things like general practice, dental services, pharmacies, those are all technically privately owned businesses and have been since the NHS's inception. But so yeah, that accounts for some of the disparity in our understanding of what's private and what's not. In terms of how that's changed over time and kind of what's driving that trend. So as Mary pointed out, I think often the Health and Social Care Act is associated with an increased marketization and increased competition in healthcare, and that's certainly true. But there's actually been this drive to increase competition, particularly in the provision of healthcare, since going back to the 1990s, and that has really been because of a real policy focus on expanding patient choice and improving access. But that's not to say that the Health and Social Care Act didn't bring with it significant changes and sent a real clear message about the importance of competition in terms of driving quality and improving services overall. And with it contained regulations and changes, for example, that made commissioners practice good procurement practices and limit anti-competitive behavior as much as possible, and also got rid of any preferential status as providers based on their ownership, so whether that's an NHS provider or not. But in terms of the impact of the Health and Social Care Act, so there is evidence to show that has certainly increased the number of private companies that are being contracted to deliver NHS care. But in terms as a percentage of overall private spending, we have not seen that increase going back to my previous slide, but that's probably because the contracts that are received by the independent sector tend to be a lot smaller than those received by the NHS. But just want to add that there's certainly a different picture when we look at which services are most affected by these changes. So we see some areas of care like mental health or community services that have seemed to see the quickest increases in private delivery. And that could be because things like their contracts tend to be retendered more frequently in those areas. There might be a larger number of private or non-NHS providers in those markets. So lots of things that might explain that variation. I'm now going to turn to just an overview of how much of British healthcare is privately financed, and that could be delivered in an NHS hospital or a private one, but how much of it is actually from private income. And here, similarly, we've seen some stability over time. So it's about 1/5 of healthcare expenditure comes from private sources in the NHS using ONS data. And these latest figures that I have are from 2017, but that picture looks really similar going back to 2013 when we have comparable data. And the largest share of private expenditure tends to come from out-of-pocket payments, around 16%, followed by voluntary health insurance. But it also includes patients who might have received private funding for care through charities or other sources. Patients who privately finance their care can receive their care in independent private hospitals, but they can also receive them by the NHS, as Mary pointed out too. And though this is not universal or certainly widespread across the whole health system, there are a certain number of trusts where this is a really important source of their income. We saw data that showed that I think it's only 10 trusts that make up about 60% of the private income that the NHS earns. So certainly not widespread, but for some trusts, a really important source. And then when thinking about how, that has changed over time. So again, it has been fairly stable, but the Health and Social Care Act did bring with it some important changes. So it was that legislation that lifted the cap on the amount of income that the NHS trust could receive from private patients to 49%. Though there are regulations around that, and if any trust had planned to increase their income by more than 5%, it would have to have, for example, more than 50% board approval. But even with that policy change, we really haven't seen a surge in private income for trusts. So overall income from private patients in the NHS still hasn't changed significantly. It's about less than 1% of overall provider income, but like I alluded to, that's certainly not the case universally. And there's some trusts, particularly in London hospitals, that have a long history of treating overseas patients where that is a really important source and something we should think about as we think about through the implications of COVID-19. So then that will bring me to the next conversation. So how has COVID-19 changed the relationship between the NHS and private health services? And I think Mary did a really helpful job of laying out some of the legal implications. I wanted to bring into the conversation some other broader policy implications we might want to think about as part of this discussion. So starting firstly with private healthcare that is NHS purchased but privately delivered, so the use of private hospitals in the independent sector in particular. What's changed under COVID-19? So we, as Mary discussed, but we've seen that and in Eliana's earlier presentation, that turning to the private sector was a key way for the NHS to build surge capacity in its COVID response with requisitioning and block booking a great deal of care in the private sector. I think data I saw had 10,000 beds, 8,000 beds, 10,000 nurses, 700 consultants were all provided from the private sector to bolster our capacity and our response to COVID. And that is a relationship that we're seeing extending now. We've seen reports that the NHS might spend as much as £10 billion over the next 4 years to maintain this relationship. And that will be quite important for maintaining clean non-COVID sites to be able to reduce our backlog and waiting lists that have built up over the course of COVID-19. Again, that I think Eliana's data helpfully illustrated the extent of the challenge that we have here. And we've also seen other agreements reached in terms of newly announced training partnerships. So for a lot of NHS trainees, their courses have been disrupted and their training, and now that is something we'll be able to rely on the independent sector to be able to have that continuity. So we're just seeing lots of changes in these dynamics as a result of COVID-19. Another area of privatization that I haven't spent as much time on, but certainly has been a factor in our COVID-19 response, was the outsourcing we've seen for things like testing, the labs, use of labs, support and recruiting return of workers for inactive personnel. These are all ways that the NHS is working with private companies in different ways than they were maybe before COVID-19. It'll be interesting to reflect on the implications of some of those relationships. And I also want to add here the impact that COVID-19 has had on the health and care voluntary sector. So voluntary sector is another form of non-NHS providers that are really important to the sector. And we've seen that they've taken a massive hit in terms of COVID-19, in terms of their ability to raise income. These services provide some essential care for the NHS, and it's unlikely that those services will be the first to be cut by any means, but we have seen in surveys with the charity sector that COVID-19 has having really important implications, and it's important, I think, that we consider that the knock-on effects that might have for non-NHS provided care as a result of COVID-19. So yeah, some questions I think I've been left with that would be interesting to discuss in terms of private care that is privately delivered but NHS purchased. So it is likely, given the enormous task ahead of us to manage waiting lists and recover services to pre-pandemic levels, that the independent sector will remain an important part of our recovery. That's something we certainly is being signaled nationally. But I think there's real questions about, well, what extent will those ongoing relationships with the independent sector result in additional capacity? How well will the NHS be able to make use of those relationships? And yeah, how much extra capacity will it really be? So I ask that because I know we've heard that there were challenges at the beginning of the pandemic, at least maybe because of how quickly these relationships were formed, for the NHS to make most efficient use of that sector. We still don't know how much activity was delivered by the independent sector so far throughout the pandemic. That's something that is currently being investigated, and I don't think is yet publicly available. But it will be interesting to reflect on what that has looked like and what we should be considering moving forward. It's also the case that many independent sector hospitals are smaller. They are not fully equipped to deliver the same services that NHS providers do, particularly for more advanced or critical surgeries and procedures. So it's just, I think, thinking really clearly about what is the extra capacity that we are getting, where is it most useful and effective to use. And there's also, I think, Eliana really helpfully pointed out some of the workforce challenges, but it's also the case that many of the staff that work in the NHS are the same staff that work in independent hospitals and private hospitals. So as the saying goes, we can't rob Peter to pay Paul. Where is there that overlap? What are we really using the independent sector for? Is it to provide extra clean space and beds, which is undoubtedly needed given that the NHS is going to need many, many, many more theatres if it's going to deliver the same levels of activity it could previously because of everything that's now required around infection control. So I think it's undoubtedly important, but we really need to think critically about how we use and make the most of that relationship. Thinking through further on other COVID implications for privatization. So moving to care that is privately funded but NHS delivered. So here we've seen, because of COVID-19, a real reduction in private work, I guess, which wouldn't be surprising given how services were blocked both from the independent sector and restrictions that were placed on other non-urgent care. Data on this is really hard to come by, but from what we've been able to see has been there's an 84% reduction in the episodes of privately funded care. that we saw during the peak of the COVID-19 pandemic compared to previous years. There's data from insurance billing data that we're able to see that some activity, like an oncology, we're seeing a return now to pre-pandemic levels, but still as an overall level activity in June, it's still less than half of what it was in the same period in 2019. So I think, so with that in mind, some questions that's posed for me, and which should be really interesting to have your thoughts on, is whether or not private access will be reduced overall as the NHS continues to use independent sector facilities and capacity. And if that's true, what will happen to those patients that would normally receive private care? Will they go back on the NHS waiting list? How will that be managed, and what are the implications for that? What impact will longer waiting times have on the demand for private health insurance is something I think is important to monitor and think about. There's research from the Institute for Fiscal Studies that has shown that there is a positive association between demand for private health insurance and local waiting times. So what will we see play out as a result of COVID-19? And though perhaps a smaller problem, but just thinking about those trusts that receive over 10% of their income privately, what will happen to that revenue? Will that be sustained, particularly if it's from overseas patients and given the travel restrictions that we now are living with in COVID-19? What might be some of the policy implications there? Before I close, I just want to quickly talk through some of the broader international experience with the private sector and how the UK compares. So we've done research at Nuffield to look at how over 30 different health systems are attempting to resume and recover health services as we go through the next phase of the pandemic. And one thing that stood out to us is that over half of the health systems we looked at have been turning more to their private sector for resources and to build extra capacity. So we see health systems that have both a public and private provision, that they've been turning increasingly to the private sector to add extra capacity in terms of testing equipment and staff. That's even in countries like Germany that have far more, that went into the crisis with far more capacity than places like the UK. Many countries have secured that capacity at cost price to avoid excess profits being made, where other countries have taken a similar approach to what we've seen in England and booked that capacity. So it'd be interesting to think through, I think, as part of this question is, what's the most efficient way of managing this relationship? What are the different implications of these different approaches? And we're also seeing a large number of countries continuing to work with the private sector to help reduce their backlog and clear waiting lists as much as possible. And that's certainly happening in Spain and parts of Italy, Austria, Canada, and Greece. We know what's happening in the UK. So it'll be interesting to see how that, I think, unfolds. So just to conclude then, I think I applaud Mary's paper taking on a really important topic and raising some really important questions that I think are part of our understanding of the full implications of COVID-19. I think privatization is a really confusing topic and one that is often treated as a whole, but really means lots of different things. And I think it needs to be handled with greater nuance and policy discourse and debate. And I think that's something that Mary's paper helps us see and understand. But I think, yes, just in terms of the research moving forward, it's really placing where we are at now in the UK in that broader context and really pinpointing what the implications and what this really looks like for providers and patients, what the impact will be for them tangibly as we move forward. Thank you, and yeah, that's all from me.
Great, thank you very much, Sarah. Thank you so much for this great presentation, and in particular the last two slides opening up to the international and bringing a little bit a perspective. I think it is important, and your conclusions. Mary, if it is okay with you, because there's some conversation going on in the chat box, I would like to bring more questions, unless you are really wanted to answer Sarah on a specific point. I'd like to take in more in the discussion. Maybe you jump in a bit later. How do you feel?
Yeah, I'm happy to say. I'd like to say thank you to Sarah for an excellent presentation and for providing original context, particularly setting the discussion in the international context as well. But yeah, I'm happy to take questions as well if you'd rather. do that.
I think it is good to have an informational context, because as you say, like having private providers is a standard in many countries like Germany, and using private capacity for testing, it is the rule rather than an exception. So I actually wanted to, with this, jump into first John Appleby's question, asking what is the problem, what is the issue of having private providers. John, do you want to jump in and turn on your video? I can't see you. Can we see John?
He's on mute.
Oh, hi. Sorry, I didn't. Yeah, I suppose it's taking a step back from privatization and asking the question, why should we care about it? Whatever it is, whether COVID has, provided a sort of trigger for doing something different, or the change in the relationship and so on. In a sense, what's the issue here that's being discussed? And is it about, do we care who owns the means of production in healthcare? Or is that a sort of second order issue?
Okay, do you want me to take that, Zainab?
Sure.
Okay.
Sure.
Thank you for that question. I think it's a very clear question. It's in a sense, of course, you could say it doesn't matter and it shouldn't matter. On the other hand, how this gets linked with, I think, the underarching principle of equity comes into play here. So insofar as it's a public provider or an independent sector provider or a sector provider, whoever can deliver certain commitments and certain expectations, then absolutely right. I don't think this does matter. But once we're starting to be able to draw distinctions between the focus and not just the focus, but the perceptions of the focus of a private provider who may be concerned with maximising profit for shareholders, for example. How does that sit within a wider framework of universal access to healthcare? I'm not playing a slightly devil's advocate with that, but I think it matters because of the wider implications associated with different types of provider.
But isn't it there the one issue is about, as you say, it's the equity of access, or having two-tier healthcare?
Yeah.
And the main issue is who pays. Is it the public provider or private provider? I mean, it's nicely in the paper that you provided the schedule, but I think you don't put enough emphasis on this, because it's from France, it is more shocking in a sense, or disturbing to see patients paying and getting a different treatment in a hospital, in a public hospital or private hospital, than public system paying private providers. And from patient point of view, there's no two-tier treatment forcibly. You are treated the same if you're treated by private providers, public providers.
Yeah.
So I don't want to monopolize. I'd like to jump to Terence Chang, who has questions on what the private providers are doing actually. And don't hesitate to share your own experience as a participant, how things have been as to the private sector in your countries.
All right, thanks. I'm actually in the car right now, so I don't think I'll share my visual. Just out of curiosity, because over in Australia, the case numbers have actually been much lower than that in the UK. So we didn't really had to use private sector capacity. It raises, I was kind of thinking about our experience in Australia. The one question I always had was the extent to which the private sector capacity is substitutable for the needs of the public sector to respond to the pandemic. The other question I would have also is on the response of private health insurance, because it is also the time where, because of the restrictions on elective care, essentially the private health funds are reaping excessive profits because they have not been able to pay out much in terms of benefits. I'm just wondering about the experience in the UK.
So just to try and clarify the questions, I'm reading the questions in the chat as well. So in terms of how much of the private sector capacity was actually used, I don't know if Sarah can provide any more insight into that. That's not data I have. In terms of, is there responsible for private health funds? In terms of health insurance, or?
Yeah, the response by health insurers of private health insurance policies.
Again, there is this collective agreement which is specifically referencing private medical insurance patients. So there is some continuity within access to private healthcare from that perspective.
I mean, I don't certainly know the full picture, but one thing on the topic of private health insurance we've seen reported in the media, at least here in the UK, is that patients who have private health insurance have not been able to use it during COVID-19, and companies have had to reissue refunds, and because there just hasn't been, because of the new relationships with the NHS and other restrictions that have been placed on the ability to get elective care during this time. So I think it has had implications for the industry overall, and it'll be interesting to see how that continues and how as a result of some of these changing dynamics.
So do you mean that it has actually negative impact on access to care in a sense? So because you couldn't get an intervention even if you wanted to in the private hospitals?
Yeah, I think we've seen access to care impacted both for NHS patients and non. I think the patients who've put off going to care or who've been unable to get needed care, I think it's happening in both markets, both sectors, as what I've seen as for private as well as those who receive publicly financed services.
Could I make a brief comment on that? Would that be okay?
Sure, go ahead.
Sure, just to say, I think we need to make an important distinction here between urgent treatment and planned care. So certainly on the privately funded side and on the NHS side, substantial efforts were made to make sure that things like urgent cancer treatment could continue. There has been disruption absolutely on the planned care side for both NHS and private patients, and that was a policy decision at national level to try and clear as much capacity as possible across the health system to avoid it being overwhelmed by a potential COVID surge. One just brief point on Terence's question about utilisation rates. As you'd expect, kind of patchy. Some areas, particularly in cities like London, where there were, I think, more coordinated efforts to drive up high levels of utilisation. What we've seen in other parts of the country is some places where that utilisation was not as high, but of course the purpose was to provide as much buffer capacity as possible, not to fill every bed. Certainly that was the objective in March through May. And the last thing I'd say is that substantial amounts of staff and equipment from independent sector providers went into what they called the Nightingale hospitals, temporary facilities that were built to take to take COVID patients across the country. So there were areas in which those resources were just used in a different way. So the utilisation of a bed in a hospital probably isn't the best measure of whether you've kind of got value from that arrangement.
Yeah, I think there were similar arrangements in many countries, and the question that Eliana asked in the session before, what's going to be the impact of all of this retarded care on the long term, even if there were some cancer patients treated. And there is some question from Dorota Osipovic on the shift of competition policy. It's somehow, as you presented this as a less competition. And Dorota, would you like to step in?
Yeah, sure. Thank you. Thanks, Mary, for your presentation. I enjoyed it a lot. I think my question is more about the disjoint at the moment that is taking place between the sort of legal framework that is in place still and hasn't been reformed, and what's happening actually on the ground in terms of how the services are being commissioned. So, and definitely the shift away from the use of, or at least the rhetorically, and probably in practice, the use of sort of competitive procurement as a means to commission services towards more collaborative or partnership approach, like integrated care systems and STPs and things like that. So I was wondering whether you had any thoughts on how this kind of policy environment and policy landscape can impact the role of the private providers or private provision within the NHS, whether it's a threat or opportunity, and also in a way on your conceptual framework as well, whether that's something to think about.
Thank you for your question, Dorota. I think I'm going to say first opportunity, possibly more opportunity than threat. So, sorry, I just saw another question there about the policy exclusion orders, what they change. I think what they change and what the framework changes there is it brings things out into the open more than has been the case before. So yes, there's been years of competition reforms in the NHS, competitive procurement, talk of anti-competitive behaviour and so forth, and there's been obviously the shift away from that, which was due to be enshrined with the NHS long-term plan. As far as I know, that's still the plan. But with the responses to COVID, it's giving an extra sort of layer to sort of establishing that cooperation rather than competition between the NHS and independent sector.
Sure.
Yeah.
Yeah. Thank you.
Brian, do you want to say something about Irish situation? It's not really a comment, but I think you just seem to say that the situation is the same.
Thanks very much, and thanks Mary and Sarah for a very interesting presentation and discussion as well. I suppose, yeah, just a similar situation in Ireland. So no, there's probably a greater degree of overlap between the public and private sectors here, where we have nearly half the population covered by health insurance, and some people are being treated as private patients in public hospitals, and then the public system then treating some public patients in private hospitals as well. So it's a very complex situation. But for 3 months, the HSE, which is essentially the equivalent to the NHS in Ireland, took over the private hospitals. Now, I suppose they took over the private hospitals, and that was fine. However, they didn't actually fully agree the procedures with the private consultants. So only about half of the private consultants in the private hospitals signed up to the agreement. So there were a lot of concerns about continuity of care for the private patients, and particularly in outpatient settings and so on. So there wasn't the full use of the private capacity during the 3 months of the agreement. Now, there was an option to extend the agreement on beyond the 3 months, but that wasn't taken up because the capacity wasn't really needed in the end, because the public health measures meant that the surge in capacity, and particularly I'll come back to what Elena was saying earlier on, we have a much reduced capacity in terms of hospital beds and ICU beds compared with most other countries, but they weren't overwhelmed, which was the big fear at the start. So but the interesting thing though was that as the insurers, because the bulk of private hospitals treat private patients, because the insurers couldn't access the private hospitals, they ended up refunding their members for the duration of the 3 months of that agreement. Now that's obviously finished now, so it's kind of back to a variation of normal, if you like. But it's interesting just to kind of compare and contrast that with the UK situation and with the Australian situation that Terence was talking about earlier on as well.
Mm-hmm.
It's actually interesting because in France we have a huge capacity of private capacity. Despite that, public hospitals were really flooded in the first period of the COVID, because the reflex was not to count on private hospitals forcibly. And it's interesting that both in UK and Ireland, you seem to say that you did mobilize all these extra capacity, but it's not really used at the end. It actually is a subject of comparative analysis on this subject. So I just noted. With this,
Mute.
oops, we're almost end of our time. So Mary, would you like to just say a couple of points?
Sorry, I'm just aware that John Appleby, I think, maybe had another question, seemed to be waving, or?
It's more a comment. And John, do you want to jump in?
Not waving, but drowning. No. Just wanted to, just to reinforce that the National Audit Office, which for those of you who don't know, it's one of the oldest bodies of state, and it scrutinises spending of public money to judge whether it was value for money. We had a little conference with them recently, and they are looking into all these private public sector contracts during the COVID period. And just one other thing, in fact, there is now data, we've just received it at Nuffield, which is it's called Hospital Episode Statistics. It's based on individual patient records, and we've got the data up to July now, covering the whole pandemic period. So any private hospital doing work for the NHS will have to record its work in that data set. So it's something we will look at. I think that could be very interesting to look at, just to see what resource was used, what sort of patients, and so on. So sorry, more for information.
Yeah, but John, can you just clarify if the private providers paid in the same ways as public providers? Because you have a DRG system it's the same price for both?
It should be. Under our payment by results system, if a private provider wanted to do NHS work, it had to accept the price that the NHS set. Under COVID, though, and I don't know the details of the contracts and how they were sorted out and so on, it may be that some hospitals got paid for doing nothing, but that was just the deadweight cost that had to be borne because, the fears and worries at the time of the start of the pandemic, we looked at Lombardy, we saw ambulances queuing up, we saw people in tents and so on. It's hard to take yourself back there now and realise quite what there was panic, within the Department of Health and NHS England about what may happen. And so, a whole set of measures came in, which in retrospect, the Nightingale hospitals have been hardly used. I think there have been about 20 patients in the London one, and none in some of the others. So treatments changed, doctors learned to do things differently. ITU wasn't needed quite as much as people feared. I think some of the epidemiological models were just plain wrong in the first place as well. So I think we've got to be careful looking back on this and thinking, well, people made mistakes or the deals were a bit generous or whatever. And in a sense, think about what was the sort of context at the time, really.
I think it's not about blame game, but I think it's important to look back and learn from it, because what you said is, I think, quite common, because in most countries, hospitals are paid on an activity basis, and because activity went down, including in France, Germany, I think many European countries, at the moment, all the hospitals are getting extra money for the work they haven't done. So as an economist, I think we need to look at the optimality of certain policies. So Mary, the last words for you to close the thing. Thanks again for this brilliant presentation.
Okay, thank you. I'd just like to say thank you to Sarah, and thank you to all your comments. I've certainly got more things to think about now. I'll be following up with some of you individually, if that's okay. But I hope this has been interesting for those outside the UK to have a sense of how we're handling things here in one way or another. So it's certainly interesting to see how this is being picked up. This relationship works elsewhere. But thank you very much.
Thank you very much. So thank you all for participating, and thank you, Sarah, again for brilliant discussion and a nice, interesting background.